Okay, folks, I think we're going to get started. So thank you everybody for being here with us today. And we're going to have, I think, a good discussion this morning about hospice and palliative care. And lots to think about and lots to talk about. And so let's, without further ado, let's get started. So my name is Jean Alton, and I'm with Alzheimer San Diego. I'm a Dementia Care Consultant, and I suspect that I may be familiar with some of you who are attending here today, and you may be familiar with me, and I'm glad to have you with us. I want to go over a little bit of our housekeeping here and some just kind of basic rules of engagement, I guess, as it were, and then we'll just delve right into things. I want to introduce, first of all, my colleague, Preston. You want to just say hi, Preston?
Hey everybody, I'm Preston. I'm one of the, also one of the other dementia care consultants at Alzheimer's San Diego, and I'm glad you all can join us today.
So Preston is an MSW, and he is our social work support for today. So he will be keeping an eye on Q&A and chat as we go along here. This is our esteemed panel that we have with us here today, and I'm going to introduce them in just a moment. What I do want to say before I do that is, we're talking about some very personal things here today. We have personal views and philosophies on very important issues of death and dying. And it's important for all of us, regardless of where we're at as an attendee or a professional or a panelist or whatever it might be, to be respectful of one another's positions, one another's experiences, and all of us to understand there's no one, with very few exceptions in this particular area, there's really no one right or wrong way to do things. These are very personal decisions and family decisions that come to be, and experience along the way sometimes is what makes us move in one direction or another, and it sometimes can be quite different from what we envisioned. So we just want to say that up front, that there's just, we can't be critical of one another's viewpoints or how people do things because it is so individualized. So having said that, with us today, we have a really wonderful group of people, and I'm going to go according to the slide, just because that's easier, I think, for us, from left to right in introductions. All right. And so, Jessica, I'm going to start with you, if I may. Jessica Empeño is currently the Director of Strategic Development with Lightbridge Hospice and Palliative Care. She supports clinical services there while working very hard, I might say, to advance care for the seriously ill. Jessica has a master's degree in social work from San Diego State that she received in 2001. And just back in, was that earlier this year or 2018, Jessica, you received your certificate in health law and policy from University of Arizona. Jessica is a former colleague of ours from Alzheimer's San Diego. And we know ourselves through our working with her that she brings just many years of experience and knowledge as a medical social worker, and with real specialties in dementia and caregiver support and end-of-life care. And it is absolutely my pleasure to have you here with us today, Jessica.
Thank you, my pleasure.
We have next is Dr. Lisa Heikoff from Kaiser Permanente, and Dr. Heikoff also brings with her a storied resume. She received her bachelor's degree in biology from UCSD, and then her medical degree from UCSF. and she completed internships and residencies at the University of California hospitals in San Francisco. She then did a 2-year fellowship in geriatrics, which is a point of interest because we don't have, unfortunately, today, we don't have a lot of doctors, hardly any, as a matter of fact, specializing in geriatrics. So that's a point of interest for all of our attendees to know if you did not know already. So Dr. Hykoff brings this experience and specialty to this panel. She is board certified in internal medicine, geriatrics, and hospice and palliative care. So that's quite the lineup, isn't it? She was a staff physician at Kaiser Permanente in San Francisco for several years. And then she moved to San Diego, lucky us, in 1990, where she continued to practice at Kaiser in continuing care services and home care. Another couple of, I think, really interesting things about Dr. Hykoff's career. Not only was she the physician in charge of continuing care services and home health and hospice, but she also served on the bioethics committee for over 20 years, and she was the co-chair of that committee for 14 years. And so, Dr. Hykoff, we might be hitting you up with some tough questions here this morning, because we think you're probably in a pretty good position to be able to address some of those.
I'll do my best.
Dr. Hykoff is a member of our, I believe it's one of our advisory boards at Alzheimer's, a community advisory board at Alzheimer's San Diego. And she certainly has given us many hours, volunteered many hours with her helping us with classes and talking to folks about Alzheimer's disease, diagnosis and treatment. And I'm sure you've been doing that with other agencies as well too. So we thank you for being with us here today and for just being one of our star medical volunteers to come in and address some of these tough questions. Next, we have with us Norman Trans. Do you want to say hi, Norman?
Hello, thank you, it's an honor.
And Norman is just an all-around good guy, let me just say that. And he is going to be sharing his story today, and just a brief, doesn't do it justice, kind of snapshot of it is that Norman, in his own words, was blessed to have found the love of his life when he was a younger man. He's still a young man, but when he was younger, he was 19, and he met his soon-to-be partner, Paul. And Paul was 46, but as Norman says, you know, the age thing was never a thing. And with Paul's support, Norman was able to pursue his dream of becoming a hairstylist, which Norman still does today. And he's very good, is the word I get from my peeps that go to see him. Norman noticed changes in Paul about 5 years ago after Paul returned from a family trip. And there was some, you know, cognitive changes, and he looked a little bit more disheveled. And as the story goes, which we will hear, and which many of you folks have maybe experienced, ultimately Paul was diagnosed with, was it Alzheimer's disease, Norman?
Yes.
Yes.
Yeah.
And so Norman was Paul's caregiver all this time, and then he came to a point where I guess what we would say is his tank was running on empty, and he needed to make some changes. So Norman called in hospice to work with Paul, and he'll tell us about that. Paul died on Sunday, February 9th of this year. And so we'll hear more about this love story that ended with the death this year, but goes on in your hearts. And I know that for you. You always talk about how Paul's still with you.
Absolutely, thank you.
And then I'm equally pleased to introduce Tracy Schropp. And Tracy is a certified trade show marketer. She manages marketing programs worldwide. So she's maybe she's an armchair traveler right now, but she's got some experience around the world. Tracy was raised in New York. However, her parents came to San Diego many years ago, and she followed them here. And lucky for us for that, but also especially lucky for her parents. So Tracy was able to be close to her mother, Barbara, in North County, as her mom began battling problems with vision changes. I believe it was macular degeneration. Is that right, Tracy?
Actually, no, it's Fuchs disease and
Excuse me.
a little bit more severe than that. But
Yeah, okay. So some severe vision changes. In addition to this, then there was cognitive decline going on, and Barbara was diagnosed with dementia. And so Tracy took on the role of being a researcher for her family, for her dad, who was the primary caregiver for her mom. And you all can appreciate how, that's a big role. I mean, it's a big job in and of itself. It's hard for caregivers to kind of take on all the different hats, including doing all the research to find out what's the best thing to do. So Tracy took that role on, and she supported her dad in managing her mom's 24/7 care. And things did rapidly progress this past year. Tracy's mom, Barbara, passed away at age 90 in July of this year. And at the time, she was under the care of Hospice of the North Coast. And Tracy's going to talk about her experience. They had some ups and downs throughout this. And her goal is that she wants just other people to have a much better understanding of how to engage and utilize hospice and palliative care services, and just to help by sharing her experience. So we welcome all of you folks as panelists. And I'm looking forward to hearing from all of you in terms of, what you know, what you've experienced, and what we can all do together, just as people, as a community, to grow the knowledge about these wonderful concepts and resources of hospice and palliative care. I think ultimately we can all do a better job. So let's get busy. Let's get at it, shall we? So I'd like to start, if I could, with, I'm going to start, I think, with you, Dr. Heikoff, if you don't mind. So we're talking about hospice and palliative care. And, I think Preston would agree with me, and I suspect that perhaps you and Jessica would, and many others, is that there is still a lack of understanding on the part of many people. What exactly is hospice care? Hospice and palliative care. So I'm going to ask you, Dr. Heikoff, to start with talking about actually palliative care. And then Jessica, I'm going to move to you and ask you to address hospice care. Does that sound all right?
Sounds fine.
Right. Good.
So I think there's one of the challenges is there are two ways of defining these things. One is sort of linguistically, or what is the meaning of the term palliative care and the general meaning of the word hospice care. And then there are the programs, what is Medicare hospice? What does it provide? What does it cover? What does it not cover? And so the definition of hospice has sort of evolved to mean Medicare, the Medicare hospice guidelines, because that's what every hospice follows. So I'll leave some of that to Jessica to talk about, but in a broader sense, palliative care includes hospice care, because palliative care means all care that's provided to reduce the burden of symptoms. All care that's provided to make people more comfortable physically, more comfortable psychologically, for whatever illness. So, when I kiss a boo-boo on my grandson's arm, that's palliative if it makes him feel better. And so palliative care can run the gamut from very simple things to ameliorate suffering, to the more intensive kinds of palliation that we do in hospice, which includes, intensive pain management, intensive psychosocial support. So palliative really means reducing the burden of symptoms, both physical and psychological. Now, palliative care programs, so this is the difference between the definition and the programs. There are palliative care programs in a variety of settings. Most hospitals in America now do have inpatient palliative care consultation teams who will come and talk with seriously ill patients and their family members about the course of their illness, about their choices for care at this point in time. There are outpatient palliative care clinics where you can go as an outpatient and receive that kind of comprehensive evaluation of your illness, your stage of illness, your symptoms, get symptom management and discussion of advanced care planning, et cetera. And there are home-based palliative care programs, some of them attached to hospice, sort of a pre-hospice kind of a program, and some of them more freestanding. So there's both the definition and the programs. I hope I've made that a little bit clearer for people.
I think so. I think that's really helpful. And I think that's part of the confusion.
Yes.
For lots of folks. It's kind of, is hospice a place or a thing or a concept? And it's kind of a hybrid of really, that's got some elements of both.
Right. I mean, we just mentioned hospice started in Great Britain, and it was a place that you went. It was conceived there as they used old small cottage hospitals, and you went there to kind of live out your time, which could be, many months. But in the United States, when the hospice Medicare program came into being, it was redefined as a home-based care program. Yeah.
So hospice, and Jessica, actually, I should hold off and ask this, but I've already started, so I'm going to go with the hospice is something that can come to you wherever you are. Although there are some hospice providers actually have a location that you can go to, but
Right.
not all of them.
I'll let Jessica go through that, I'm sure.
All right. Well, Jessica, why don't you jump in for us here and tell us a little bit about hospice and kind of all the different things that hospice encompasses in terms of the supports for families and individuals.
Sure. So like you said, Jean, I think when people hear the word hospice, there's a lot of misunderstandings, different things that they've heard, and fear, right? We don't really like talking about death and dying and thinking about a possible end to our lives. So it's a term that I think is really heavy and just has a lot of different meaning for different people. Some of that not necessarily accurate. And I would say that's not just us in the community, but even physicians and healthcare professionals have their own biases or misunderstandings or misconceptions about hospice too. Like, like Dr. Heikoff said, hospice started as a place. It was caring for weary travelers hundreds and hundreds of years ago. But the more modern idea of specialized care for the dying really started in the 1800s. And this modern concept of hospice that, like we know it today, started in about the 70s in the United States. And then in 1980, the Medicare hospice benefit really started. And that's when programs started sprouting up all over the place. So hospice as we know it today it's a specialized type of holistic and comprehensive care that is designed to support people that are in the final phase of life. The Medicare definition is that, if the disease runs its normal course, that we'd be looking at approximately 6 months left of life. The way I like to phrase it and the way I talk about it with families is kind of the would you be surprised approach. Would you be surprised if your family member was not here in 6 months or a year, right? Hospice is all about, we focus on support and guidance for the family, on symptom management and comfort for the individual, and really guidance and quality of life for all that are involved. Hospice really focuses on the symptom management, the palliation, like Dr. Heikoff said, for the individual that's ill, But really, we want to support the entire family, everyone that is connected to that patient. And we do that through an interdisciplinary team approach so that you've got the expertise and the perspective and help of all of those different individuals. So that every patient always has a team that's involved in their care. And like you said, Jean, hospice most usually is not a place. We go to where the person is. Most people want to die at home. Most don't, but most do. Most people want to die at home. Most people don't want to go to the hospital for unnecessary treatments. And that's really what hospice focuses on. We come on board when maybe treatments are no longer effective, or the family, the individual has decided that they don't want to continue pursuing aggressive treatments anymore. So that's when hospice can be the most helpful.
Thank you, Jessica. I really like your approach of, would you be surprised if? And if I steal that phrase from you, would that be okay?
I'd be honored.
Because I think that is something that can resonate with our families, perhaps better than some of our other explanations. I see Preston nodding his head, and I see Tracy too. You know, too often, and I know Tracy will speak to this, too often we know with families contacting us either before or after their person living with dementia has died, is hospice was not brought into the picture, or palliative care, until, you know, really end of life, like last few days, the last week of life. And you've referenced already that really a person, you know, according to the qualifications for hospice, it's a matter of, it can be up to 6 months. Would you be surprised if your person living with dementia were to die in these next 6 months? No, I wouldn't be surprised. Well, then let's start hospice, right?
The Medicare hospice benefit is clearly, 6 months or less, approximately. Nobody's got a really well-tuned crystal ball at this point. But the average length of stay for someone on hospice is about 7 days.
Yeah.
So yes, people are waiting till the very end. And sometimes it's physicians that are waiting to make that recommendation to the end. Sometimes it's families that are having difficulty with decision making. So if nothing else from this conversation today, my best advice would be to do what's called advanced care planning. And that's simply sit down and have a conversation. Talk about, what do you want? How would we want this to go? I think too many people fear dying. And this is one of the reasons that I am so passionate about hospice, is dying doesn't have to be scary. It doesn't have to be painful. You don't have to be alone. And that's where the experts in hospice, we are trained to, especially for somebody with dementia who may not be able to communicate their wants and needs, their pain, their discomfort. We know that untreated pain is a huge issue in people with dementia, right? It's hard for them to communicate,
Absolutely.
to recognize what's hurting and where and why. But in hospice, we understand that. And we know how to read the face, read the signs and the symptoms, and make that a little bit easier on everybody involved.
Terrific. This is exactly what I wanted our discussion to kind of encompass. We will, I do want to come back to your, not right at this moment, but in a little bit, your very important point about planning advanced directives and, kind of the steps we need to take and the talks and discussion we need to have long before hospice. It's the pre-work that needs to be done long before. So we will come back to that. But it is, I totally agree. It's a vastly underutilized, both these areas of palliative and hospice care are vastly underutilized. And that's my passion of what we need to change, So having said that, what I'd like to do is go actually to Tracy. And Tracy, what I would like, if you don't mind, is if you would just share with all of us here a little bit of your story with your mom. And you and I have talked, we've talked lots. And there were just some bumps in the road for you. And if you would, I'd like you to just kind of share that experience with everyone so that we can all just think about it and take it to heart and hopefully be people who can walk away from today's session and say, well, I don't want that to happen to my family or to the people I know in my community and the people I care about. Let's take this little nugget of information and help people to prevent these kind of bumps in the road from happening at end of life. So
Yeah.
fire away, Tracy.
Okay. Well, Jessica, that I agree. I want to steal that too. Would you be surprised if your loved one wasn't here in 6 months? Because, we didn't really think of it that way. We kept thinking, with Alzheimer's, this could go on for years. So we tried everything, and it was a lot of the problem was the medications and not getting those straight. She was on pain meds, she was on sleeping, she was up all night, she was on agitation, and the neurologist is prescribing one thing, the internist another thing, caregivers are suggesting other things, nothing was working. And we didn't know where to go. And if you Google hospice, it does say 6 months every time. And we're thinking, well, she's not ready for hospice. And no one even suggested, funny enough, palliative care, which I thought was interesting. Even, people in the field, or maybe the doctors didn't notice because they didn't see all of what was going on, the different ones. The caregivers, I don't know, I just thought that was interesting because when I went in and started researching palliative care is when I found out palliative care and hospice care are connected, and that, like Dr. Heikoff said, it's really, hospice is part of a palliative care. Well, I didn't know any of that. So I learned that, and that all you need to do is get a doctor's order, and it doesn't have to be that 6 months, but we started with palliative care, and they said, you know what, she really is eligible for hospice care, get the order. So we did that. We found out that we could go to any hospice we wanted, which was some confusion with the doctor's office. They didn't realize it at first. So we learned that, and we learned that, they could come in and start looking at your medications and help you with that kind of stuff, and that they actually supplied medications that you wouldn't normally get. So it became that what we thought was an emergency kit was really a comfort kit, and that really made all the difference to us. But basically it was what I wanted to be a part of today is for people to realize that, like Jean said, to take advantage of these services way earlier. I think we could have helped her so many weeks earlier. And the other thing is that I think it's good to know that there's the signs. If you could kind of figure out that, it's time, since no one's suggesting to you, hey, have you thought of palliative care? Or, it might be time to call hospice in. Nobody was saying that to us. It'd be nice to know some of the signs that you should start doing that. So it's really helpful for this webinar, thank you for having it, for people to know that the first step I would suggest is start with palliative care and just start looking into it. And from there, they will suggest and guide you to the next steps.
Well said. Dr. Heikoff, you want to?
Yeah, I just wanted to comment. Part of the challenge with hospice and palliative care of patients with dementia is that, unlike most cancer patients, although that may be changing as new drugs come out, where the trajectory is a pretty linear, there's a pretty linear decline in the patient's status once treatments are no longer effective against the cancer. In dementia patients, often there's some fluctuation. They get a UTI and they look terrible for a little bit, and then they get that treated, and boom, they perked back up and now they're eating better. Or there's a change in the home environment or a caregiver change and they decline or get more agitated, but then things settle down and they kind of get on a smoother track. So sometimes figuring out, even for the clinicians, figuring out where are you on that path can be difficult. And I think that's part of the reason people don't recommend it as quickly as they should, is they sort of see the up and down and they think, well, maybe we should wait a little longer, or a little longer.
Yeah.
And then the next biggest, a common big challenge with dementia individuals is the whole feeding issue. And that opens up another whole, bag of worms, but how is the eating going, and how aggressively does the family want to push is maybe the wrong word, but really strongly encourage oral intake or use artificial means to feed the patient, and how does that play into how things are going to evolve over time? So there's some unique things that happen with dementia patients that I think is part of why clinicians aren't as good at projecting where we are in the course of things.
Mm-hmm.
And we need to rely on families, because really the families have a sense. The families know. They can say, this isn't just like when she had a UTI last year, something different is happening.
Yeah.
It kind of sounds like to me, that we all just have to come to the table as family members and individuals with our healthcare providers and bring in our hospice advisors. Call Jessica, have her come to the table with you, with your physician as well too, so we can have this discussion and figure out what is in the best interests of my person living with dementia. Jessica, what would you chime in with on these thoughts?
Yeah, I definitely agree with everything that Tracy and of course Dr. Hykoff was saying too. And I think that, even asking for an evaluation, there's no harm in that. If you are usually what we say is if you're thinking about it, it's probably time. So ask for that evaluation. There's no harm in that. No harm can come. I think some of the kind of logistics of hospice versus palliative care in San Diego, there are organizations that use that phrase, hospice and palliative care, because they do so often go together, but they only truly have just a hospice program. There are organizations that have a separate and distinct palliative care program to where a person could receive palliative care. So palliative care, being that it's designed to focus on symptom management and basically comfort care, it can be received alongside curative treatments, aggressive treatments, but for a lot of people, it is kind of a nice natural pathway to hospice care. And again, they will come to your home and provide that support as well. And every program operates a little bit differently. So that might be something to think about too. And really you can talk to your doctor about it to ask for a referral, or you can also just call the hospice or palliative care organization directly and say, we get these calls all the time. I'm not sure. I don't know if it's time, but I'd love to talk to somebody and I'd love for you to come look at my person and tell me what you think.
Good.
And social work can also help with that. I think that sometimes the physicians don't really know, but if there's social work services within your system, that would be a place, to seek some advice as well.
I was just a little surprised that the caregivers that were there every night and seeing her with that nobody even, that they wouldn't suggest, like, have you thought of palliative care? Or, just to get started, like ask for evaluation. Thought that was interesting.
I think care for people with dementia and, to some extent in our healthcare system in general, really focuses on acute episodes. It focuses on, treating the pain, treating the symptoms. And I think that sometimes it overshadows the underlying condition, right? The dementia, that there's a bigger disease process here. I mean, it's hard to say, but truly, dementia, Alzheimer's disease, it's a terminal condition, right? There's no cure, there's no recovery, there's no survivors. It's a terminal condition. We know the path that we are on and where it's going to lead. So at some point, we need to be thinking about planning for that final phase of life.
So, and this is what I was thinking, Jessica, as you were talking and earlier actually even, is that really we can be talking to our families about palliative care, perhaps even in the moderate stages of the disease already, if not even earlier. You know, just kind of depending on the situation, but encouraging people to start looking at those options. I mean, palliative care can come in while they're, you know,
Yeah.
still participating maybe in a research study or some other such thing.
Absolutely.
And then,
And the palliative care might be there to be helpful for maybe other health conditions that they're dealing with.
correct.
Most people are dealing with chronic conditions,
Yeah.
multiple chronic conditions.
Mhm.
And so then maybe the palliative care is really to help manage all of the other chronic conditions and chronic diseases that a person is dealing with, right? Lung disease, kidney disease,
Yeah.
hypertension, diabetes, all those kinds of things. And, you know, that focus on treating the whole person and looking at everything that's going on with them it can only be a benefit.
Yeah. And I guess,
I love
you know,
that.
I guess what I'm thinking too is just, you know, palliative care in the sense of, you know, bringing, addressing pain and suffering. For people with dementia, what I'm thinking about specifically is agitation. I mean, agitation is pain and suffering.
Absolutely.
Huge.
And so palliative care can really come in and address that with all the specialists of the medical team. Dr. Hyckoff?
What I was going to say to emphasize Jessica's point, one of the biggest challenges in that pre-hospice phase, the palliative care, focusing on quality of life, is juggling the meds, the medications, because as you say, you may have meds for this and meds for that and meds for this and meds for that, and they often have contradictory side effects. So many of them are what we call anticholinergic side effects that actually make the dementia worse and cause sedation and increase confusion. And so you do need the skills of the palliative team usually to look at the whole picture of the medications and say, you know what, at this point, we're going to set some priorities. These medicines are still very important. We'll figure out the right dosing. These can be left at the wayside, especially if there's issues with cooperation and taking the medicine. Are you going to have a big fight over their vitamin D at this stage of their life? No, we can set some things aside. We can reduce some doses. And even the the dementia meds per se, the Ariceps, et cetera, can have significant negative side effects, especially late in the course. And so encouraging people to think about letting go of some of those meds because they're really not helping and maybe hurting in the later stages has to be considered. So the medication management gets very fine-tuned and finessed, and you need somebody with some experience to do that. And palliative care consultants or a specialized dementia clinic would be another option for that.
That's exactly where we were at, and exactly what was a huge, like I was saying, was big. One of the biggest problems when you're like on the phone with a pharmacy, you know, at nighttime trying to figure this out. I think you need help.
Yeah.
Yeah.
And, you know, I mean, we're not as family caregivers and, you know, it just says health professionals. Tracy, were I in your shoes, I, you know, might be slightly better informed in some areas, but in many I wouldn't be. I mean, I would be on the phone to the pharmacist as well too. I'm not a doctor. I don't know. So it's just, I think, speaking to the importance of working within a team. And to that point, I would like to invite Norman to speak up and tell us a little bit about how and why you engaged hospice. And I'm going to let you go with it. I just love the way you tell this particular part of your life experience, how you express it.
Thank you. Thank you so very much. First of all, I really want to thank you all for being here and what an incredible job you guys do. I was very blessed to have had my partner for almost, well, it was 36 years. I cannot stress enough how important the advanced care directive is to do at a very early stage, like not waiting till we get older, you know, because we never know what's around the corner. But I was very fortunate that we had done this. Like I said, there was a 27-year age difference, and I was very fortunate that we had done this when I was about maybe 25 years old. And when you do this, not only are you putting like your life in the other person's hands if they can't do something for themselves, but it's the greatest love that you could give somebody. So that being said, you know, I was very fortunate, I feel, that my partner and I, that all family members were on the East Coast. And I was very fortunate that I was able to actually kind of do this on my own. I didn't have other input from other people because I kind of felt like I knew what was best for my partner. So the analogy that I really kind of like to give is like, we've all been like on road trips before, and you know, you have other people in the car and somebody's saying, stop here, like go this way, you're going too fast, watch out for the bump. And it's the person that has the wheel in the car that is actually driving the car that knows what they want to do. So I felt very blessed to kind of like have the wheel on my own. But again, as we've all been on those road trips, whether it's a road trip or whether it's our loved ones, we get exhausted, and we keep on hearing people say like, you have to take care of yourself, you know, and it's like, yeah, but I'm the only one that can do it. And I have to say, you know, that when I finally kind of like, when I was so exhausted, I was almost into 3 car accidents within a month because I was falling asleep at the wheel because I was so exhausted. When I finally gave the wheel to someone else, which was hospice, it was such an amazing relief just to sit back, and I could then make better decisions because I was now thinking with a clear head. And when you are so sleep deprived, you are making the worst decisions. And until you are so exhausted to where you finally say, I can't do this anymore, you're doing the best thing possible for your loved one. And I heard something very, very special just real quickly, just this morning, that our loved ones will teach us so many things in life, but they don't teach us how to live without them. So again, I feel again very blessed that I had somebody for almost 37 years. And the important thing also that I have to state is I have no regrets whatsoever. I don't wish I would have said I loved you. I don't wish I would have held his hand one more time. I have no regrets. So they can always hear you, even though you think that maybe they can't or they're being difficult. Just know that they always know that you're there.
Norman, you always make me cry a little bit because of your deep love for one another.
You know, hey, you know, we go around like once, and you know, it's the people. You know, I heard a beautiful saying. You know, that I had to listen to it a couple of times because I didn't quite understand it. But you can't choose the people around you, but you can choose the people around you. So sometimes if you have difficult people around you, you can pick new people to put in your place. And that's exactly what hospice had done, was they were absolutely amazing. Yeah, so thank you.
Yes.
I think one of the things that Norman expressed here today, and which he's expressed to me in our conversations, is, you know, when he did kind of give up that driver's seat role and allowed hospice to come in, one of the gifts of that was Norman could go back to being Paul's partner, not being Paul's caregiver, medication administrator, personal care attender, you know, and so forth. So you could go back to being the couple in a different
Absolutely.
way that you have been up, throughout the course of your lives together, but still to go back to being partners.
Absolutely.
And
Yeah.
and I think that is just something that's really important, that gets a little bit sometimes, I think, lost in the shuffle of caregiving. Jessica, what would you say to that?
Well, first, I have to just say, Norman, thank you so much for sharing that, and everything you said was just beautiful, and everything that we hope for. It's what we want that to be. It's not easy, but you don't have to go through it by yourself, right? There are all of those people that can be there alongside you, to help you take the wheel. I love that analogy. That's beautiful. So absolutely, I mean, anytime you are dealing with somebody, you're trying to support somebody that's ill, wouldn't you love the ability to just pick up the phone and talk to a nurse and say, this is what I'm seeing, this is what's going on, I'm not sure, what should I do? Those kinds of, I like to say that hospice is just a giant safety net.
It is.
It's 24/7 support. They're not in your home 24 hours a day. That's not what part of the hospice benefit provides, but it's 24/7 support. So to have a nurse that's stopping by to check on your person once a week, once every other week, to see how things are going, to check on the meds, make sure symptoms haven't changed, right? To have people in the home and to know that you can call, so that you can just take that burden off of yourself, and you can focus then on being there and being a family and being a part of those days, to enjoy those moments. I think that is priceless.
I certainly would agree with you. Dr. Hyckoff.
Well, I do think it's important to emphasize that hospice doesn't just come in and stay with you for the duration. And there are limits to the services that are provided. And if you need that 24/7 coverage, you may need to hire some private caregivers, or if you have a family or other people that are coming in to share that in a shift care sort of way. So it's a mixed bag. You do end up still needing to keep a close eye. You can't, you're still a backseat driver if not holding the wheel. And so I just think that's important. Sometimes people do have the expectation that hospice will come in and just take over everything, and are disappointed to find out that that's not the case, and it is not cheap to hire private duty people. And I don't know, Jessica, there are other levels of care that hospice provides. There's crisis care, where hospice does come in for a more intensive period of time, but usually just for a limited number of hours or days. There's respite care, where a patient can go somewhere for care to give the caregivers a break. I'm wondering if it's difficult now with how COVID has changed some of that. Is it harder to hire private duty caregivers? Is it harder to find facilities for respite care? Because who wants to put their loved one in an elder care facility right now, right? So some of the benefits that exist might be harder to enact right now. I'm curious as to how that's going for people.
And this is a very good and very salient point. And actually, Preston, I'm going to ask you if you will step in at this time and speak to what Dr. Hyckoff has just referred to with regards to in-home care and residential care during COVID times, because I know this is a discussion we've had many times over these past few months in our family services team.
Absolutely. I think there's been, when we were right at the beginning of all this, back in March and early April, I feel like it was, there was a lot. I was astounded and just by the resilience that our families had going through this. Just, they understood that this was a new world that we were entering, and that they were going to be really cautious with who they were going to bring in. And they were adapted pretty well to the idea that, okay, these services may not be as easy to access and we're going to get through it. But unfortunately, as the time has gone on, and you all, I'm sure can imagine, just the stress and just keeps piling up for our clients, and it's and the need for respite and in-home care is there, and it's I would say it's just the same as it was pre-pandemic. And so now the unfortunate thing is there's a lot of services from in-home care providers, that they've had to they're not as flexible as they used to, and who they can send out. There's staffing issues across the county. Adult day programs were a really big resource for a lot of different families, and the majority of them are still closed at this time. And there's just less options. There's less volunteer programs that can go into homes at this time as well. So really the big options are pretty much in-home care, which is increasing in price as well, and their staffing is can be difficult. So the need is still there. So the ability, if your family does qualify for hospice, and there are some good questions in the Q&A that we can get to as far as how that looks, as far as what different symptoms. I think people are trying to figure out, well, what are the direct symptoms that hospice assessments that the hospice providers are assessing, and they say, oh, that this is okay for hospice now. I think if you're trying to bring in as many resources as you can into the home as possible, and if you can bring in hospice and palliative care, I would go ahead and do it.
Thanks, Preston. I appreciate that. So yeah, so for sure, families are having additional challenges and struggles right now.
Can I also add too that, the other thing that the pandemic has done, we've all heard about the isolation that this pandemic is creating. And so, what I'm seeing is there's a lot of people that have resided in residential care facilities that, because of the restrictions, they're not able to visit. And a lot of facilities aren't even allowing the window visits that people were doing in the beginning, because they have crowds forming outside the facilities, which was creating problems. So I'm seeing a lot of families that are giving it a go, taking their person out of the facility and taking them home, which is definitely creating challenges on its own. And, there is no assisted living or residential care facility in San Diego that is accepting people that are positive for COVID. So that is creating challenges. And, the skilled nursing facilities, being able to find a bed, whether you're COVID positive or not, has just become more and more difficult. And the harder that becomes, the less available respite beds are. Because like Preston was saying, we're all struggling with staffing. We've got, everybody that is a nurse, that is a caregiver, they have personal lives. They have families that they're trying to take care of and get through the pandemic too. People are getting sick. People are worried about getting sick and are making some tough decisions. So it's definitely made it harder on everyone and has changed the game.
Sure has. And, we're still in the thick of things yet, and with the surges that we've seen in positive cases, we've got a ways to go. So it is a challenge. It's a challenge for all of us, individually, as people of the community, as professionals as well too. Jessica, we can just share with you and Dr. Hykoff as well too, just the frustration of when families are calling us and needing and looking for support, and we really have not a lot to give to them, and that's very disheartening.
The good news is the vaccine is coming. I mean, there's very positive news, and it looks like healthcare workers and nursing home residents are going to be at the front of
the list. Yeah.
And so, a few more months of this, it's tough. And if you're it's like the people who die of COVID alone and, you know, without family visitors.
Yeah.
You can end up in a bad situation just by luck.
Yeah.
But in a few more months, we should start to find our way out of this.
I agree with you, and I do agree. It is positive, and yeah, we need to look forward to getting our, you know, healthcare professionals and providers protected and in better situation to be able to continue doing their very important jobs. And, you know, and then from there on, we'll hopefully in a matter of a few months and certainly within a year that we can all get together, whether it's by webinar or in person, and we're all vaccinated and out of the woods on this one. So, so thank you for those, you know, very important perspectives on the additional challenges that families are facing in these times. And Jessica, I just would agree with you that we've heard from many families at Alzheimer's San Diego who have made the decision to take their person out of a memory care facility, and you know, because of COVID and because of the visitation restrictions. So you know, we've got some work still cut out for all of us here down the road. Preston, I think what we'd like to do right now is, I know some questions have been coming in here on the Q&A. So let's go to those. If you'd like to just have a look at a couple of those and see what you think would be, you know, kind of valuable for a majority of people to hear about. I think I've seen a couple of questions regarding the very specifics of initiating hospice or palliative care. What have you got for us, Preston?
Sure. I think one place that I think would be really helpful for a lot of clients, and I think maybe starting with Dr. Hykoff and Jessica as well on these, is from your perspective, from a physician's perspective, or from a hospice care provider's perspective, what are the symptoms that you're looking for to say, oh, this is going to be an appropriate referral for palliative care and or hospice care? I do realize that when it comes to dementia, we have a saying, you know, when you met one person with dementia, you met one person with dementia. There is that individualized considerations in all cases, but are there certain symptoms that you're looking for on your end, that anything general or any kind of common themes that you may see when you're working with clients? Because I think a lot of, I hear that from when the clients call in all the time. They're just like, well, I have this, but is this common? Is this the right place to go? So just curious what you guys feel that may be.
You want me to start? So I think,
yeah, either of you is fine.
Sure. At a basic level, I think what we're going to be looking at is, we're looking at where are things today? What are the symptoms? How is the person doing? Are there, you know, things going on with them that we could be managing better that need that support? But we're also going to be looking at really painting the whole picture. How did we get here today? So for example, you know, some of the changes are so subtle that we don't always pay attention to them. Weight loss is a really good example. You know, we have somebody that weighs 100 pounds today, and that was probably a very gradual thing. But if we look back 6 months ago and they were actually, you know, 150 pounds, that shows a change. That shows that things are changing. Something's going on there. Why are they losing that weight? Is it disease process? Is it because they're having difficulty eating? So we're going to look at the whole picture of what's going on and see, you know, what we might be able to do to support that, and what could use better management.
Dr. Hykoff.
Go ahead.
You know, the Medicare hospice guidelines are quite specific and somewhat detailed, and so we can no longer use terms like failing to thrive or generalized decline. We really have to give very specific criteria, and that's frustrating to people because they can see a gradual decline, but if the person doesn't meet those specific criteria, they don't meet Medicare hospice criteria. Should that be the case, then you should then look for a palliative care program, whether an outpatient or a home-based one. And a lot of the outpatient, we're doing our outpatient palliative care mainly by video visit now, which is actually much better suited to dementia patients because they're at home, they can come on and off screen and their caregiver can participate, and it actually is more suitable than trying to bring them into the clinic environment sometimes. But the criteria have to do with the FAST scale, F-A-S-T. I don't know if people are familiar with it, but it's a 7-point scale that grades the level of dementia. And for a person to qualify, and you can just look this up on the internet, Dr. Google, for a person to qualify for hospice, they need to be in that FAST 7 level of decline. And that usually means they are not mobile, they're no longer ambulatory, they can no longer walk. They need assistance with most of their activities of daily living. They have to be fed, they have to be changed, they're not continent. They have lost almost all of their verbal skills down to just a few words, 7 words a day. They've lost their ability to emotionally react, smile and react emotionally to people. So this is a very, very late stage, advanced stage of dementia that meets the hospice criteria. Weight loss, certainly 10% weight loss in the last 6 months. It's a big one. Difficulty swallowing, which can happen as the disease progresses, all can lead to this. But I think that's what shocks people. It's like, I can see the decline. I can see, where she was in July and where she is now, and things are really declining. And no, I wouldn't be surprised if she wasn't here in 6 months, but they don't quite meet those criteria. So that's where a palliative care program can help fill in those gaps and address the needs, the medication management, the psychosocial needs, and the anticipation of, when things will change in the meantime. But that FAST scale is something for people to take a look at if you think, what's wrong with my doctor that they didn't see the need for hospice. And unfortunately, we do live in the real world. Unfortunately, Medicare comes in, Medicare certified hospice, Medicare comes in and evaluates every hospice periodically. And if they see people on the hospice service that have been there for a year, they're going to do a deep dive and they're going to say, why did you keep this person on? They clearly didn't meet these FAST criteria. And so the hospices themselves can be very careful about bringing dementia patients on and making sure they meet the criteria. So that's an external regulatory thing, but it definitely impacts what happens to people and why some providers are very cautious about these referrals. So it never hurts to ask, it never hurts to get the information and get the evaluation, but you kind of need a backup plan if it's not quite time yet.
Okay.
One of the things I would add too is, I know at Alzheimer's San Diego, you talk about preparing for a doctor's visit and how to partner with your physician. And I would recommend the same thing before you look at an eval or having a conversation with the doctor about the possibility of hospice or palliative care, is to prepare in advance. What are the things that you're seeing? What has changed? What are those symptoms that you're seeing? Why do you think it's time? What is it that you're concerned about? And help provide as much of that information as possible. And that will help you be the best advocate that you can be for your person.
Yeah, that's good. Thank you.
Perfect.
I'd like to ask just Norman and then Tracy, for each of you, what, if there was kind of a thing that made you say, I'm going to call hospice, what was that thing or that event or that time? Norman?
Like for myself, it was just like the constant, taking him in and out of like the hospital. He had fallen several times at the facility where he was at, and he ended up getting a large gash in his leg. So after 5.5 hours at the emergency room, we got him back to the facility, and it was like 1 o'clock in the morning, and he had fallen on some bricks in the garden, and he had another skin tear. I was so exhausted, I just couldn't take him back to the hospital again. So we got him all cleaned up, and, just the falling, not being able to no longer eat. It was just getting to be so much, that it was definitely time to have hospice come in.
And you had, and tell me, I'm not sure exactly the lineup of this, but you had already done some research into hospice and kind of were prepared to move forward with making a call?
Yeah, so again, like I said, there were several trips to the hospital, to the emergency room, and one of the social workers ended up talking to me about hospice, and had just given me just some information, and I just really thought it was now a really good idea to, that it was just too much for me to take on, and the facility, because the facility had so many people in there that they needed to take care of. So it was just really time to get his meds, get him off of some of the meds, to make sure that he was comfortable. That was the main, comfortable and safe. And, so yeah, it was a great experience.
Good. And, shout out then for the social worker, the hospital social worker who, had the foresight and the insight to avail you of those resources. Yeah.
So the resources, is, we never get enough information, so that's why these webinars are so important.
Tracy, how about for you? What was kind of the thing or the trigger or the incident or the event?
It was a rapid decline, partly because of her sight. She was falling a lot as well. And stopped really being able to just have conversations and feed herself even. She stopped picking up the fork. The medications, safety and comfort, definitely. Between the medications and she would cry out, actually, that she was ready to go. And so, I thought we would be able to just call hospice, but I didn't think she'd be eligible because of that 6-month thing. So again, started with palliative care and called hospice of the North Coast. And they said, no, Tracy, your mom's probably eligible for hospice. I said, oh, okay, So we skipped right to that. Never even got the palliative care, which we could have done the palliative care, like I said, I would think weeks earlier, which would have been given all of us better time together. But we were really lucky because we did get the crisis care, which means they took my mom to Pacifica House in Carlsbad. And we were able to be with her there for days. And it was very peaceful, and that was great. But yeah, I would say we're just hitting our heads against the wall, and caregivers weren't showing up, and she just couldn't be alone 24/7, not a minute. And we knew it was just, everything was failing, basically.
Yeah, it was a tough time for you folks.
I think she was telling us, and I think she was telling us it was time too.
Yeah.
So.
Tracy made reference to Pacifica House. This is an actual facility location that Hospice of the North Coast has, and this is where her mom Barbara was transitioned to for her end of life days, and under hospice care of this particular organization. And I know that they helped turn it around for you folks, and I'm grateful for that, because you had a tough haul there. You had a tough haul.
I wanted to comment about the hired caregivers and sometimes caregivers in memory care facilities.
Mm-hmm.
Bless their hearts. They get very attached. They're there day in and day out. They're feeding people, they're changing people, they're bathing people. And they sometimes like Tracy, you mentioned, like, why didn't the caregivers say something? They get very attached, and they get attached to their own role in keeping the person going sometimes. So they're not always going to be the one. I mean, if you want to be really cynical about it, it's their job and they don't want to, lose their employment. But I think it really is, it's a special group of people that do this kind of care, because God knows it takes, an incredible amount of patience and humor. And they're often not going to be the one to say. They in fact sometimes pride themselves in keeping the person going and how much they ate today or at this meal. So that's just something we see, and it's a good thing in a way, because it shows their dedication to the care, but they're unlikely to be the one to recommend hospice.
Yeah.
And the only other point I need to make is that you can come on hospice and have it extended if the person lives past 6 months. There are 2-month extension periods, so it's not an absolute, like, you gotta fish or cut bait at 6 months. But and you can come off hospice if you somehow or other level off and come back on later. There's no like lifetime limit or anything, so you do have that. It just doesn't hurt to explore it.
So a couple of very important points there is that there is no lifetime limit. You don't get one shot at hospice or palliative care. So you don't need to save it for, those last days. And we have, fortunately, not as many people as I would like to hear from at Alzheimer's San Diego, but we have had some who have been on hospice and have rallied and kind of improved, and then they've come off hospice, and then there's been more disease change and they've gone back on, and this has been an on and off situation, which actually is really ideal. That's really what we want. Would you agree, Dr. Heikoff?
It's a mixed bag, because changes of people coming in and out can be confusing to the person with dementia. So if they get used to a particular bath person who, the home health aide is coming in and giving the bath, they get into a routine, and then 6 months later, that person's gone. Then you have to hire somebody private duty in the meantime, and then there's a whole new routine. So yes, it's good in terms of the philosophy of care and presumably the medication management and the planning and all that it's good to have done that, even if it's not quite time yet. But sometimes just in the nuts and bolts part of it can actually be hard on patients and families.
True. Very good point you bring up. I think what I'd like for us to do now is just shift gears just a little bit here to go back to talking about the work we need to do long before hospice and palliative care comes in, which is advanced care planning. And so I'd like to, if I could, Jessica, go to you and just get your thoughts on all the important stuff that we need to do to be preparing to have those talks and those discussions about what end of life is going to look like for us as individuals and for the people who may be our care partners. And I will just say, additionally, we do have a legal and financial basics webinar class at Alzheimer's San Diego, where we do have elder law attorneys coming in to present those classes and talk very specifically about the documents. We offer those quarterly. We do have one up on our website currently that is from about a month ago or 6 weeks ago, that you can have a look at that. We will be offering that class again come the new quarter in 2021. So Jessica, if you would, please.
Absolutely. Advanced care planning is one of those things. There's actually a lot of research behind advanced care planning showing the immense benefit that it can have for a person's quality of life at the end of life. So reducing unnecessary hospital visits, reducing unnecessary trips to the ER, treatments that they may never have wanted in the first place. But it also takes a huge burden off of the family, who has that opportunity to feel like they know what to do in a situation, right? You've heard those sayings of, if you wait until there's a crisis to make the decision, not only are your options fewer, but it's much harder to make decisions. So advanced care planning is just that. It's planning in advance for what the care is going to look like. You can do that with a professional. Absolutely call one of the social workers at Alzheimer's San Diego, sit down with them. They can be part of it. You can also do this as a family, maybe over Zoom now instead of around the kitchen table, but getting together and just talking about it. Put out on the table what you feel is important. What do you want things to look like? If the person with dementia is not able to participate in the conversation, think back on what you know of them in their life. What would have been important to them? If we know that they always loved music, music is extremely powerful. Let's make sure that they're surrounded by music that they love, by good smells. Those kinds of simple things are a really good place to start. It can be an easy place to start the conversation. But then we definitely do need to get into some of the legal documents that can help make advanced care planning have a little bit more teeth to it, if you will. So like Jean said, the legal financial planning class is great. If you haven't done that, I would definitely recommend it. Look at an advanced care directive, look at even a living will, but thinking about who's going to make decisions when the person can't, and make sure there's a backup, right, in case that person is unavailable or something's going on with them. Also, talking through a POLST. A POLST is really important because we need to have conversation about what about when it comes time to our person is not able to eat anymore. How do we feel about IVs and artificial hydration? How do we feel about tube feeding? Those kinds of things are going to be really important to just flush out and have that conversation so that when the time comes, it's like insurance. You hope you never need it, but you're glad to have it if it's needed.
Dr. Hyckoff, tell us a little bit more about the POLST and when do we need to be completing POLST forms?
So I would just start with the advanced directive. An advanced directive really should be completed by everybody who's 18 and older. I had my kids do it when they turned 18, because sometimes actually those are the hardest situations. A young person gets in a car collision and has a severe head injury, and you have to make some tough decisions. And who's in charge? Is it the parents or is it the partner who maybe they're married or they're not married? Or we went through this during the AIDS epidemic, and it really, it became very clear that not having the ability to legally assign somebody to be your decision maker was a big vulnerability. So I did all my training in San Francisco in the 80s. So, that really informed a lot of my experience and led to my interest in hospice care, actually. So an advanced directive, the most important thing it does is assign a surrogate decision maker, somebody who will be your decision maker when you lose the capacity to decide, and some backups, as needed. And particularly for patients with dementia, where both partners, the caregiver, may be equally aged and stressed from being a caregiver, and something could happen to them, and now you don't know who the next in line is. So very important to have some depth of that assignment. And you can specify other things on an advanced directive, but you don't have to. It's a place to put more kind of subjective things about what is quality of life, what's important to me, do I want to avoid pain, how do I feel about artificial feeding, and it's a place where you can put some kind of generic information, but whatever you want in your advanced directive. A POLST form, and POLST, P-O-L-S-T, stands for Physician Orders for Life-Sustaining Treatment. These are actually physician orders. They get signed by a physician or a nurse practitioner or PA, and they are legal medical orders that cannot be breached by a paramedic or anybody else as long as they're there and visible for people. This is for when a person has a life-limiting illness. So you don't have an 18-year-old fill out a POLST or a healthy 60-year-old fill out a POLST. When a person receives a life-limiting diagnosis, that's the time to create a POLST. Because the POLST addresses, do I want aggressive intensive care? Do I want more intermediate, treat infections and give me some IV fluid, but limit the aggressive life support? Or do I just simply want comfort care? And you can change your POLST at any point in time. You can make a new one. If the decisions you made are no longer relevant, you want to change those decisions, you can do that. As long as you have capacity to do it, mental capacity to do it. So a patient with dementia cannot complete a POLST. They do not have the capacity to make those decisions. A POLST, however, can be completed by the person who was the assigned surrogate decision maker in the advance directive. That's why the process should really be, do the advance directive early on when you're healthy, change it as you need to. Like I had, my siblings as my surrogates after my spouse. And then when my kids got to be over 30, I said, I'm going to change it. So all of these, just like changing the batteries in your smoke detector, once a year, you should take these documents out, take a look at them and say, are the people that I named in here still appropriate? Has anything changed that would make me want to change these documents? The advance directive, as long in advance as you can, and the POLST at the time of a life-limiting illness. And again, each of these documents can be adjusted, changed based on circumstances along the way. The POLST does need to be discussed with a medical provider because they need to sign it in order to make it a legal document. And then you want it available in the home when you have a sick person, particularly on hospice. And the hospice teams know all about this and will work with you to make sure that if something happened and you had to call the paramedics, you had to call 911, I don't know, they fell, they were in pain, you called paramedics, that they know what the limits are and they don't provide interventions that they don't want.
Norman.
Jean, I would just like to add to exactly like what the doctor had just said was, when people were actually taking other people like to the doctor's appointments or to the hairdresser or whatever, I also recommend that everyone had a copy of that in their car, whoever's involved with that person, so that if you're out and about like at Target and something happens and the paramedics come, I think it's just important to have that everybody's on the same page, that somebody's not doing something that the patient wouldn't want.
Very good point. And, these, I'm going to show you a slide right away with some websites on it. Don't worry that you have to copy it down. It will be included in the handout that comes to all the attendees. But the POLST form is usually done on this really bright pink piece of paper that once it's completed and your physician has signed off on it, if you keep it on your fridge, keep it visible. And it's a very bright pink, trust me, you can't miss it. And as Norman said, have a copy that's transportable, that goes with whoever people are involved in the caregiving. You keep yours on your phone?
You're muted.
Muting and unmuting.
Yeah.
You can take a picture of it and keep it on your phone.
That's a good idea. That's a good idea.
That's great.
So I'm just going to share my screen with that. Where are you?
I also was going to add that because we had the POLST for my mom. Actually, my dad has one now too, even though he doesn't have any kind of issues, but he's 91 and he got his at the same time. I guess there's no reason why you can't have one if it's already discussed, but the thing I'm going to try to say is the advanced directives were not matching with the POLST, and we went, that we need to make sure they match.
Yeah.
That's something else I would urge people to talk about.
Agreed. All
That's
right.
why you need to review.
Mm-hmm.
Yeah, absolutely. Yeah. So I think I have just put up the slide that's got, I think the POLST, the website for the POLST form is at the bottom, but these are some good websites for you folks to have a look at. The California Hospice and Palliative Care Association, the Centers for Medicare and Medicaid Services, and the Coalition for Compassionate Care of California, and then the National Hospice and Palliative Care Center. So what I want to do, we're kind of coming close to the end here, folks. What I want to do is go back for a moment to all our panelists and just to ask you, what are your final thoughts, your words of wisdom for all of us? And I'm not going to give you any more direction than that. What's your final thoughts? Jessica?
My final thought would be, don't be afraid to talk about the hard stuff. Have the conversations, educate yourself, understand, you know, if you're going to fill out a post, understand what each of those options mean. Just because you can have things like IV hydration and artificial, you know, feedings, doesn't always mean you should. Understand the risks and the benefits, especially when we're talking about somebody with dementia. But have the conversation.
Agreed. Absolutely. Norman, what about you?
You know what? I'm just, like I said, I was just very, very blessed, like to have had somebody for like 36 years, you know, so I could have had this person for 10 years. So I'm very, very blessed that I had them for this long. And this person's always with me, constantly showing signs, you know, so just because someone is physically not here, know that they're always there.
Thank you, Norman. And to your point, I mean, there's lots of things we didn't get to talk about here today, folks. And amongst those things is, you know, is kind of the after part when, and for gosh sakes, all along, you know, we talk about the ambiguous grief when we're dealing with folks with dementia, that as the dementia is progressing, that we're kind of losing them, but we're kind of not. And then, you know, death does come, but that it's not over when our person dies. It's not over yet.
You know, I have to just throw in real quickly that the facility where Paul was at, I was very involved with everyone at the facility, all the residents, and obviously this is before COVID. You know, so I was doing bingo games, I would help out in the kitchen, I was very, very involved. So when I ended up like getting the call, I had rushed there, but then I had to go to work, and I knew that that's what my partner wanted. So I had brought a teddy bear that we had gotten years ago from a bed and breakfast. And I had the healthcare worker just put the teddy bear like up by him. And I had asked her, I said, when you do me a favor, when he passes, would you please open the window so his soul can leave? Now it was February the 9th. It was freezing cold that Sunday morning. And he passed like at 9 o'clock in the morning. And literally his soul is, so, you know, again, there's this, it's not an end, it's a beginning.
Mm-hmm. Thank you, Norman.
Definitely.
Tracy.
Yeah, I definitely feel, you know, yeah, I agree. Better place, right? Definitely. I guess I would just say, you know, I do honor all the caregivers and the hospice givers and all that. And, you know, I just wish we could have had them more and more in our lives because they really saved us so much. But I would just ask a lot of questions. Always ask a lot of questions because it's just not out there. People, like you said, we started this whole webinar today about like, you know, it's people aren't educated, and that's why this webinar is here. Thank you so much for doing this. And I would also say that the one on advanced stages webinar would be, people should really look that up. I think you got a video of it on your website, and I really think that's very helpful as well.
Thank you, Tracy. And yes, in 2021, we will be offering that, preparing for the late stage. It's actually going to be two classes that are involved in that come the new year. So be watching for that on our website. Dr. Hykoff, final words of wisdom for the moment. There's always more wisdom to be had.
Always. I would just say that one of our taglines in hospice is when people are anxious about this, taking this step and think they're giving up on their loved one by doing this, that what we do in hospice and in palliative care as well, we're not giving up hope, we're changing what to hope for.
Mm.
And I think that's another approach that families can understand, kind of takes it down to basics.
I like that a lot. Mhm. Okay, I got a couple of more things I want to just share with you here. Let me just want to make sure I got a nice screen here for you. So I want to do some special thanks to our panelists here today. And so let me just start with this one, which is my special thanks to Norman and to the love of his life, his partner, Paul. And this is a photograph of them holding hands that Norman sent in to me. And I just love it. Thank you, Norman.
You're welcome. Thank you.
And then look at this. Isn't this the sweetest picture? Special thank you to Tracy and to her family and to her mom, Barbara. And this was Tracy and her mom on her 87th birthday. Is that correct?
I think it was, yeah, whatever I said. Oh my gosh, I forgot I sent this to you. Yeah, about that, about 87, yeah.
So,
3 years ago. Mm-hmm. Thank you.
Thank you, Tracy.
Mm-hmm.
And of course, to our esteemed professionals who you've brought so much to today's panel, and I thank you for that. And I will continue to be seeking your wisdom and knowledge and experience over the coming months and years, likely. Much to be learned from you ladies. Jessica and Empeño, I apologize for mucking up your name there here at the end, from Lightbridge Hospice and Palliative Care, and Dr. Lisa Heikoff from Kaiser Permanente Continuing Care. We so appreciate your contributions here today. And I'm just doing a quick shout out for all of our programs and supports at Alzheimer's San Diego. And please call us, folks. I know we didn't get to all of your questions here today, but give us a call and we'll be happy to delve into things with you. There's a variety of different ways you can get in touch with us through our website by calling us, but also Preston sent out in chat a link to request follow-up. If you complete that, that will come back to our team of social workers who can follow up individually with you regarding your situation and any questions you may have. Lastly, we do have some online education still coming up through the end of this year. Living with Memory Loss, which is next week. Managing Resistance, being presented with Elder Help of San Diego on the 10th of December, and Coping with Personality and Behavior Changes on December 17th. And then be looking for our lineup of online education for 2021. We would love your feedback, so when we wrap things up here in just a moment, you will receive a link to an online survey, and we do appreciate any feedback that you can give to us. You will be getting a copy of some program materials from today, and that will be going out this afternoon. And a recording of today's program, I'll be honest with you, I'm not quite sure if it's going to be in our webinar library or not as yet. So it may be. So, but have a look around in our webinar library for some of our other programs as well too. So I think that's it for today, folks. My thanks again to everybody. Appreciate you all so much. Stay well, stay healthy, take care of yourselves and one another and the people you love. Good wishes for everybody.
Thank you, Jean.
Thank you.
Thank you so much.
Bye, everyone.
Bye-bye.
Bye-bye.